From the screen, we can see that this is a relatively young male patient. He is 59 years old, and the past medical history and the risk factors include hypertension, and he is a heavy smoker, and we can see that there is a hyperlipidemia. He accepted PCI for the RCA 3 years ago due to the, old myocardial infarction. However, he complains the chest pain for 1 week and recently, and admitted to our hospital. And the body check include, we can see that the hypertension is not that well controlled, with a systolic pressure 140 over 94 millimeter mercury. And let's check. We can see that this is a laboratory data, and we can see he also suffers hyperlipidemia. So we have this patient on the well medication control. And ECG demonstrated sinus rhythm with ST segment, depression from the anterior lead of the ECG. And ultrasound indicated normal heart function and also the structure of the heart. So our, preliminary diagnosis for the patient is coronary artery disease, unstable angina pectoris, and hypertension, etc. And this we can see that this is a totally occluded LAD with mild to moderate stenosis with the body of the left main. And also we can find there is a very focal severe stenosis in the mid circumflex with the OM branch proximal part with some, diffuse long stenosis. This is another projection which better demonstrated the stenosis in the body of left main and also the circumflex. For the angiography from the RCA, we can see there is a very long stenting from the mid distal part of RCA directly to the proximal ostium of the RCA branch. And also there is a collateral flow from the distal RCA through the septal branch to the distal LVD. So we can see that the occluded segment is relatively long from the angiography. It's totally over 20 millimeter. And several collateral flows connected to the septal branch to the LVD. So this might be a potential retrograde case. And we can see that from the baseline imaging of the CT angiography indicated some long diffused, CTO segment in the LVD. Okay, we can see that this is a reconstruction of the general CTA angiography. And also we can see that at the proximal junction part, shall we, call back the circumflex? Okay, circumflex is there. So one, I think that tough spot for this patient is that this is a blunt tip, total occluded. It's hard to tell where is the entry point of the proximal part of the LAD. So from the CTO angiography, we can see that at the proximal part, there is a very blunt tip, totally occluded. And also we can see the plaque composition is majority is I think fibrotic from this composition with a mild calcification at the ostium of the LAD. We also know that this kind of CTO with a bifurcation is very high risk of failure from the antegrade because there are some patent, cell branches.
This case is very, the lesion is very complex because of the opto LED CTO lesion, and we cannot confirm the proximal cap location. And for this case, I think we should try the retrograde approach firstly, and then we build antegrade approach. And I think the better method or the technique is the reverse cut to recanalize the LED opto CTO lesion. And the risk of this lesion is if the retrograde or the antegrade Y cross the lesion from the subintimal opposite side of the carina of the circumflex and LID after stent implantation, the large branch may be lost, and it will induce very dangerous complication.
And we can see several, relatively very long stenting segment can be detected in the proximal and also the mid RCA. And also we found that there is a very focal severe stenosis in the proximal of the OM branch and also the mid part of the circumflex. And the RAD is totally occluded. So before we work on the LED, first we use a balloon to dilate the focal severe stenosis of the circumflex, and one stenting has already been put in the mid part of the circumflex. And later we may check the angiography as well as the IVUS image of the circumflex. So it's well expanded and no dissection. We can see that this is relatively 2.5 to 7.5 vessel as a mid part of the circumflex. And this is before the stenting, after the pre-dilation. Since this is a very severe, heavy plaque burden, a long, relatively diffuse lesion. And let's check the final stenting, instant result of the circumflex. And now we are checking the instant result of the circumflex after stenting. So we can see the distal part of the stent is well expanded. There is no hematoma, and also we can see that the whole severe stenosis has been covered. And there is a very hint, not so clear. We can see that something, okay, we can see it seems to be a very small entry point from the antegrade. However, I want to emphasize that this kind of, how to say that entry point, however, is on the side part. It's not in the center part of the vessel. It's of a relatively high risk from antegrade of going into the subintimal space because we can see that this kind of entry point is very close to the intima. We just mentioned that this patient has several choice for the retrograde entry point. And from the distal part of the RCA, I think it's highly likely to be the PRV branch that several connections has been made through the distal RCA to the septal branch and goes up directly to the septum. And finally, this distal one is relatively the most smooth, not so tortuous, and relatively with a good, direction one. So currently we can see that the part of the wire has already been going to the septum. And eventually we can see that it goes into the mid part of the septum. However, we want to emphasize, and later we may check the bilateral angiography of this patient because this kind of connection from the distal RCA through the septum to the distal RAD is not that clear. The relatively flow is not so clear. Maybe a CC level 2 with some tortuosity at the mid part of the septum. So we can see that the wire upgoing so retrograde is meet some resistance and have some difficulties. And also, I want to mention that the retrograde microcatheter we have several choice during some clinical, usage. Okay, I think that we have already goes into the left main. We can see some mad plaque composition on the bilateral, on the side part of the left main. There's some fibrotic plaque. And also, okay, this is the left main body plaque. We can see some mild intima dissection, but we don't worry too much about it because we can see that currently the residual lumen area is okay. Here is some, so it's over 5 millimeter square with some mild, tissue dissection, but it's not a big issue. And also, we can see that during the retrograde report, we know that uh, where upgoing is of key importance, and we can see that Professor Gong has managed to cross the most tortuosity part of the septum branch. And also the other relatively smaller microcatheters, such as Caravel, we have uh, Turpic LP and the Frank Ross, etc., may be easier to deliver, especially through the smaller caliber epicardial collaterals, but provides less support for the crossing complex, for example, heavy calcification lesions. And also, microcatheter from the retrograde can confirm that the retrograde wire has crossed through the collateral into the distal true lumen, and also make some tip injection to confirm the distal part of the wire is in the true lumen or not. Okay, thank you, Professor Gong. I think that we can see that Professor Gong is also working on the retrograde wire crossing. I think that for this patient, the most, tough spot is that this is, we just emphasize, this is a blunt tip, totally occluded LED with no clear entry point from the antegrade. Goes up to the bifurcation site. And also the insertion of a guide wire into the set branch, which is difficult, can act as a marker for the, how to say, the set branch origin. And also we can try to use a balloon inflation in the set branch or non-inflated balloon and can block the wire. And also we can try to use a dual lumen microcatheter from the antegrade in this case. However, it's not a guarantee for the right entry point puncture. So we can see that we are still using the retrograde approach as the first choice in this patient because there are several predictors for the antegrade failure in this patient.
Cross the segment collaboratory, but unfortunately the retrograde microcatheter cannot cross. Um,
So did we try the how to say the caravel microcatheter or change to another catheter to try to
we'll
go?
change another.
Mm-hmm.
This the proximal
Mm-hmm.
maybe a good choice.
Okay, so you think that the one proximal to this choice? Mm-hmm.
But the proximal sand branch is closed to the distal
Yes, distal,
head.
yes, CTO segment. So you need to make a very sharp turn after you
Uh,
go through the septum branch,
yes,
which is a relatively
very.
difficult choice. I think the most often used is 0.8 millimeter or 1 millimeter with relatively quite shallow, something like 20 to 30 degrees, although some morphetors use 90 degrees bands to allow for tracking very small, very sharp angled tortuosity collateral flows. I think this is of key importance. And we can see that Professor Gong is trying to choose another collateral flow as a more proximal part of the this branch. It's relatively okay. We can see that we make some progress. It's relatively very smooth. Let's check whether this retrograde wire is a good choice or not.
A little contrast. Okay.
Okay, I think that we have already goes into the CTO segment. So Professor Gong, what's the retrograde wire you are using currently?
The Xian
The Xiong wire.
that we commonly use the retrograde wire. Next, we'll check if the retrograde microcatheter can cross the collaterals to get the distal target vessel. If this successful, we think we
Okay.
will make a good
Yes.
progress,
Yes.
and
I think
then
that.
we are trying a retrograde Y.
Okay, that we can see Professor Gong has managed to pass through the microcatheter through the retrograde approach. And I think that this collateral flow from the proximal part is a relatively a better choice compared to the distal one. Okay, I think that this distal part of the microcatheter has already goes into the CTO segment.
Give me, yeah. Oh no.
Okay, we can see that the retrograde Gaia third, right, is trying attempt to make the puncture. How about we? Okay, how about we try? Okay, single high volume sensor. LED CTO PCI indicated that LED CTO PCI. Successful recanalization was associated with over 92% of overall survival at 2 years. with no difference in survival between patients with or without ischemia cardiomyopathy. And also the LVD CTO PCI was associated with an absolute 10% increase in the left ventricular EF value at 9 months in patients with ischemic cardiomyopathy. Atropine 1 milligram plus IV. So we can see that this kind of medication is often used in the clinical usage. So we need to pay attention to the retrograde flow and then as well as the antegrade flow. So that we can see that this patient is triple vessel disease. We perform the PCI for the circ and RCA. There is a very long, really relatively long stenting segment in the RCA. So that's so we make a PTCA and also try to recover the flow of the ORM branch. And now we are using a microcatheter to give some high selection vasodilator for the tip of the circumflex. And like I just mentioned, that the natural prostate and natural nitrogranule is often used for the clinical usage of the CTO procedure because we can see that for the CTO cases, there is always high plaque burden and also a lot of attenuated plaque in the clinical practice. However, the occluded segment is over 20 millimeter. It's a blunt tip, and there is no severe calcification. However, we know that Professor Li Yue has just indicated from the previous operation that the JCTO scar might not be so sensitive in the predicting of the 30 minutes, for example, procedure success rate during the clinical usage. So Rector score based on the CT angiography might be potential, advantage in the clinical usage. And for this patient, the JCTO score is relatively higher. Okay, let's make a pullback. Pulling back. Okay, I think that the situation of the left main has some changed. So maybe Dr. Gong, I think that one stand as the left main is a good choice. What do you think?
Yeah.
Okay, Professor Gong, I think this is a relatively big left main. However, the circumflex is not, osseum circumflex is not so big. So I think how about let me check, maybe over okay. How about 3-5 stand, 3-5 stand from the osseum circ to the left main? What do you think? 3-5 stand.
3, 5.
Okay. Okay, currently the patient is in stable situation. We can see the pressure is okay and the heart rate is okay. And next, we are going to put in stand because we can see that the situation in the left main has changed. So one stand is unnecessary for this patient. 可以吧？啊，对，6。Okay, we are opening the stand. What, 6? Okay, 6. Okay, I think that stand is well expanded. Maybe we pull back a little bit and open it again. Okay, the stand has been well expanded and we do not worry too much. So this is a potential high risk that we have been always emphasized through the whole procedure.